Welcome to the 13th video in a series looking at the transmission of the COVID-19 virus around the world. In this video titled Countdown to a Disaster, we analyse how the United Kingdom prepared and managed the impact of COVID-19. The United Kingdom currently has the fourth highest confirmed cases of COVID-19 in the world, and has the third highest mortality rate. Why? In 2007, Dr. David Hyman from the World Health Organization said of the UK is still in the vanguard of countries worldwide in preparing for a pandemic, and is also one of the leading global players in addressing the cross-sectoral issues in their planning. How did the UK, who apparently was one of the best prepared for a pandemic, suddenly become the worst? In these next views, we look at the sequence of events as they occur across the world, initially in China, and then the steps taken to give advance warnings for countries to prepare. On December the 31st last year, the Chinese authorities in Wuhan informed the World Health Organization of a cluster of cases of pneumonia. On January the 1st, the WHO sets up its incident management support team. On January the 6th, the WHO published its first disease outbreak news. Also on January the 6th, the WHO posts on social media reports of a cluster of pneumonia cases in Wuhan. On January the 10th, the WHO issues its first technical guidance. On January 13th, China shares its genetic sequencing of COVID-19. On January the 14th, the WHO warns of potential for human-to-human transfer. On January the 20th, the WHO experts visit Wuhan in China. On January the 30th, the WHO's Emergency Committee declares a public health emergency of international concern. Basically, this is a heads up to the rest of the world, to be prepared, for a pandemic. On February the 3rd, the WHO publishes strategic preparedness and response plans for the rest of the world. On March the 11th, the WHO declares COVID-19 a global pandemic. In this view, we look at the global pandemics and epidemics in the 20th and 21st century. In 1918 to 1919, there was a Spanish influenza A pandemic, H1N1, with a mortality rate of between 20 and 50 million. In 1957 to 1958, there was the Asian influenza A, H2N2, and it had a mortality rate of between 1 to 4 million. And then in 1968, there was the Hong Kong influenza A, H3N2, mortality again was between 1 to 4 million. In 1976 to currently, there was the Ebola viral hemorrhagic fever. It's a zoonotic disease, transmissions from animal to human. The mortality rate is currently 14,267. There was the SARS, which is severe acute respiratory syndrome, zoonotic disease transferred from animal to human, and that killed 774 people in 2002 to 2004. In 2009 to 2010, there was a swine flu influenza, and that originated in animals, pigs to humans, and that infected roughly about 1.4 billion people with a mortality rate in excess of 500,000. There was the Middle East Respiratory Syndrome, MERS, again zoonotic. It killed 886 people, and again that was from 2012 to currently. And then last year, severe acute respiratory syndrome, SARS-CoV-2, we know it as COVID-19, again zoonotic, infected over 4 million people, ongoing, mortality in excess of 300,000 and ongoing. Zoonosis refers to the disease that can be passed from animal to humans. They are sometimes called zoonotic diseases. Animals can carry harmful germs such as bacteria, fungi, parasites and viruses. These are then shared with humans and cause illness. Zoonotic diseases range from mild to severe, and some can even be fatal. Zoonotic diseases are widespread across the world. The World Health Organization estimates that 61% of all human diseases are zoonotic in origin, while 75% of new diseases discovered in the last decade are zoonotic. Before the introduction of new hygiene regulations, around 100 years ago, zoonotic diseases such as tuberculosis, bubonic plague, and glanders caused millions of deaths. They are still a major problem in developing countries. A major factor contributing to the appearance of a new zoonotic pathogen in human populations is increased contact between humans and wildlife. Zoonotic diseases are increasingly linked to environmental change and human behaviour. Logging, mining, road building through remote places, rapid urbanisation and population growth is bringing people into closer contact with animal species they may never have been near before, as well as the exploitation of wild species have created a perfect storm for the spillover of diseases from wildlife to people. In these next views, we look at what the United Kingdom did to prepare for the arrival of the COVID-19 into the United Kingdom. On the 25th of January, the FCO advises against travel to Hubei province in China. On January the 28th, the FCO advises all but essential travel to mainland China. On January the 31st, the first case of COVID-19 detected in the UK. On February 25th, the government's guidance is all travellers returning from Hubei, Iran, and certain regions of South Korea should self-isolate on reaching home or their destination, even if they have no symptoms. On January the 3rd, the government publishes its 4-stage action plan: contain, delay, research, mitigate. On March the 5th, the first death in the UK due to COVID-19. On March the 9th, the FCO advises against all but essential travel to Italy. On March the 14th, the UK is criticised over its apparent herd immunity. March the 15th, the FCO issues a travel advisory for travel to Spain and United States. Also on March the 15th, elderly and at-risk individuals are advised to self-isolate. On March the 16th, the PM advises against non-essential travel and going to pubs and clubs. On March the 17th, the FCO advises against all non-essential foreign travel. On March the 18th, all schools are closed. March the 20th, the UK government closes all pubs, clubs except for takeaway food. On March the 23rd, the UK announces a UK-wide partial lockdown. On April the 14th, the UK charities report that older people are being airbrushed out of official figures. On May the 11th, the Stay Alert message from the UK government was classed as confusing and nonsensical. Scotland, Northern Ireland, Wales and the devolved governments decided to maintain the established message, stay at home. From June the 8th, all arrivals to the UK, except from the Republic of Ireland, will be required to self-isolate. The vast majority of countries have implemented extreme border controls. The UK has very few border controls. During the period of the 1st of January to the 23rd of March, there were 18.1 million arrivals into the UK, of whom 273 were formally quarantined. Between the 1st of April and 26th of April, there were 95,000 arrivals into the UK. 93,000 of them were UK citizens. 42,000 were non-citizens. Many of these arrivals came from COVID-19 hotspots. No checks at point of entry, no screening, no testing, and advised to self-isolate if they became symptomatic. There was no mandatory quarantine or follow-up for those. In the next few, we take a look at a country that has been very successful in managing the COVID-19 outbreak.
What's the actual number? On the 16th of April, the Health Secretary said it was 15,000. What's the actual number now?
The actual number of people coming in as of Friday, the 24th of April, was 9,906.
Great. And what's your estimate of the proportion of people arriving at ports and airports with coronavirus?
Well, we don't have that data because it is a fact that obviously we don't have our overall approach to international travel and checks at the borders have consistently been informed by SAGE, the scientific and medical advice provided by SAGE and Public Health England. So there is no testing at the border, and that is a cross-government decision based upon SAGE advice and medical advice, and also with the Department of Transport.
Australia banned travel from China on the 31st of January. It then closed its external borders to non-citizens and residents on the 20th of March. And all residents were banned from departing Australia. And on the 3rd of April, Australia states implemented their own internal border controls, preventing movements of population between states. Whereas in the UK Scientific Pandemic Influenza Modelling Summary states, screening is less effective than restricting travel generally. Preventing those with clinical symptoms from travelling is only likely to delay the spread of the disease by 1 or 2 weeks. Assuming passengers are screened before travel for clinical symptoms, there is very little additional advantage in entry screening. Screening on entry to the UK poses considerable policy questions, e.g. whether potential cases are quarantined, and planning, i.e. it requires considerable resources and is not recommended. Assume no significant disease control benefit from international travel restrictions. Assume that screening either on exit from countries, regions or on entry to the UK will not have any significant benefit for considerable costs and disruption. The data analysis between Australia and UK is markedly different. One of the major differences is the implementation of external and internal borders. In Australia, 62% of all cases detected was acquired overseas. Individuals arriving into Australia were put into forced quarantine at a government-designated hotel. Statistics are central to the coronavirus story. Every day we hear new numbers of cases and deaths. But what do they actually mean? The main thing we know for certain is that the numbers we are seeing are incomplete. That doesn't mean the information they provide isn't useful. But you need to keep this at the forefront of your mind when you're looking at the numbers of coronavirus cases. The number of confirmed cases provides a good snapshot of the outbreak across countries. But it is heavily dependent on how many tests a country is doing. If you don't test for coronavirus, you can't find it. The confirmed number of coronavirus cases is the baseline for most of the charts you've been seeing. It shows how many cases have been registered in a country over time. This is a linear chart, which is good for quickly seeing the scale of the outbreak in different countries. As you can see, the United Kingdom, Spain and Italy have the largest overall outbreaks in Europe, and in comparison, Australia the least amount of cases. There are clear differences in how well countries have dealt with it. despite a late start, than the majority of European and Asian countries. With the exception of Russia, the UK is on a trajectory to be the fourth worst in the world after the US, Russia and Brazil. This is a grim but effective way to look at the outbreak. Tracking the number of COVID-19 deaths is one way to provide a clearer idea of what's actually going on in a situation where testing is much lower. In a country like Germany, the low death rate is likely to indicate that they've got a better handle on how many cases are in the country overall. There are concerns, however, that reported COVID-19 deaths are not capturing the true impact of coronavirus on mortality around the world. The Financial Times has gathered and analysed data on excess mortality, the number of deaths over and above the historical average across the globe, and has found that death tolls in some countries are more than 50% higher than usual. In many countries, those excess deaths exceed reported numbers of COVID-19 deaths by large numbers.
Well, I think the most important thing now is that we prepare against a possible very significant expansion of coronavirus in the UK population, and that's clearly on the cards. It's possible that we will see a big expansion in the number of cases. And I just remind everybody what I've said for a while now. This country is very well prepared. We have a fantastic NHS. We have a fantastic ability to conduct large-scale testing.
The Director General for the World Health Organization says you cannot fight a fire blindfolded, and we cannot stop this pandemic if we don't know who is infected. In January, China released the coronavirus genetic code. That's the blueprint for creating tests and vaccines. Within days, labs across the world had designed tests and shared their research with others. Within about 2 weeks, Australia had its own tests, and even citizens in the most far-flung regions of the country could be tested. While the World Health Organization was telling all countries in March that they needed to test, the UK focused on delaying and mitigating the spread of the virus. Other countries continued testing and tracing while implementing physical distancing and lockdown. Australia was able to dramatically reduce its case numbers. In contrast, the UK, despite over several weeks in lockdown, is still seeing a high daily number of cases and fatalities, suggesting that the absence of robust testing and contact tracing is limiting the effectiveness of lockdown. But testing has been inconsistent in what has been a patchwork response to the epidemic worldwide. Some countries, like France, did not have a strategy that centred on testing to map the advance of the virus. Testing in Italy has been plagued by political squabbles. The United Kingdom developed tests but decided not to use them widely, as Singapore and South Korea had done. Other countries were caught off guard by the shortage of chemicals. In Britain, as in many other countries, the virus is circulating so quickly that it is no longer possible to test people and investigate whom they have infected. Despite the recent surge in testing, these early days meant Britain had conducted just 1.89 tests per 1,000 people, the lowest rate in Western Europe. Currently, the UK is testing 26.2 tests per 1,000 people. Italy's 49.5, Spain 41, Germany 37, and Australia is 40.5. Additional testing capacity has allowed the government to get a better grip on the unfolding toll in Britain's care homes. It was previously flying blind. Only several weeks ago, even symptomatic care home residents and staff did not qualify for a test. For many weeks, patients were discharged from hospital into care homes without being tested to check whether they were taking a deadly virus to a place where it could unleash havoc.
A critical constraint on the ability to rapidly increase testing capacity is the availability of the chemical reagents which are necessary in the testing. The Prime Minister and the Health Secretary are working with companies worldwide to ensure that we get the material we need to increase tests of all kinds. And as well as increasing the number of staff on the front line and the tests which protect them, we must also increase the capacity to provide oxygen to those worst affected by the disease.
Governments across the whole world are heavily reliant on advice from experts to help guide them in making policy decisions on how to manage the COVID-19 outbreak. One of the last images of the coronavirus COVID-19 outbreak in the UK has been Boris Johnson and other government officials looking nervous and uncomfortable, flanked by scientific advisors at the regular press conferences. The aim, presumably, was to project a sense of control and authority, the rhetoric that the government response was always led by the science, was reinforced time and time again during each briefing. Certainly, the UK government's advisors have been calm, clear and convincing, articulating positions effectively across the media. But soon debates in the UK emerged about the advisability of cancelling mass gatherings, isolating at-risk groups and school closures. The UK position was seemingly out of kilter with other science-led policies elsewhere in the world. The science suddenly did not seem so singular and certain as competing scientific views confronted with each other. As all scientists involved know, things are very uncertain indeed. Defining a policy is a judgment call, one based on assessing many competing positions. Indeed, many of the decisions are currently being made in the realm of ignorance, where the outcomes of the likelihoods are simply not known. This next section will explore the timelines, the debates within science and advice given to the UK government.
At all stages, we have been guided by the science.
Well, I think that if you were looking for the sort of uniqueness of the British approach, it would simply be those initials you mentioned, the Chief Medical Officer, the Chief Scientific Officer. It is a real desire to be driven by the evidence and by the science. Now,
at each point, we've been following scientific and medical advice, and we've been deliberate in our actions, taking the right steps at the right time.
What we do have now is evidence of countries that appear to have been strikingly successful in turning back the tide of the virus. Thailand, for example, the first country outside China to get the virus, only 59 reported cases. Taiwan, right next door, only 49 cases. Shanghai, which is in the same country as Wuhan province, is only reporting 3 deaths. Now, there might be underreporting, but most people recognise that the places that have succeeded are the ones that moved earliest to social distancing, that the business of trying to keep the most vulnerable people away from places where they could catch the virus. And so I think people will be concerned that we're not moving sooner to more social distancing.
The Scientific Advisory Group for Emergencies, SAGE, is a UK governmental advisory body that advises central government in emergencies. It is usually chaired by the UK Chief Scientific Advisor and has specialists from academia and industry, along with experts from within government, make up the membership, which will vary depending on the emergency. The group discuss number of cases, reproductive numbers and doubling times, case fatality rate, hospitalisation rate, serial interval, incubation period, behavioural psychology and communications with the public, viral genetics, vaccines and immunisation. This view details the SAGE meetings in February. On the 10th of February, the SAGE reports that it is a realistic probability that there is already sustained transmission in the UK or that it will become established in the coming weeks. The relative risk of cases in countries outside China has been shown to be correlated with air passenger levels. On the 11th of February, They said that the discussion centred around the transmission of the virus in large gatherings, pubs, clubs, private social events, etc. Agreement that all these activities and locations are high risk. The UK government did not impose restrictions until the 20th of March on pubs, clubs and large gatherings. The 17th of February, different views on whether or not sustained transmission in the UK or what will occur in the future. On February 25th, the behavioural group recommended that the government maintains regular, consistent communications. Public need to understand the purpose of the government's policy and why the UK approach differs to other countries and how resources are being allocated. They also said there should be set clear expectations on how the response will develop and promote a sense of collectivism. All messages should reinforce a sense of community and that we're all in this together. On the 26th of February, the SAGE discussed and analysed data and potential impact for school closures, home isolation, symptomatic cases, voluntary household quarantine and social distancing. On the 2nd of March, SAGE says it's highly likely that there is sustained transmission of COVID-19 in the UK at present. On the 3rd of March, there was agreement that the government should advise against greetings such as shaking hands and hugging, given the existing evidence about the importance of hand hygiene. A public message against shaking hands has been additional value as a signal about the importance of hand hygiene. Promoting a replacement greeting or encouraging others to politely decline a proffered handshake may have benefits. That same day, Boris Johnson was commenting that he had shaken the hands of several individuals diagnosed with COVID-19, and subsequently, a few days later, was still shaking hands with individuals. He later was diagnosed with COVID-19, as was several individuals who he was in regular contact with. On March the 4th, the behavioural group have divergent opinions on the impact of not applying wide-scale social isolation at the same time as recommending isolation at-risk groups. One view is that explaining that members of the community are building some immunity will make this acceptable, herd immunity. Another view is that recommending isolation is only one section of society, risks causing discontent. On March the 9th, SAGE advises that measures relating to individuals and household isolations will likely need to be enacted within the next 2 weeks to be fully effective, and exactly 14 days later, the UK government announced a lockdown. Genetic analysis, the data is consistent with a large number of independent COVID-19 introductions to the UK from multiple locations around the world. Major import to UK seems to have occurred from locations within large epidemic centres and high travel volumes, notably Italy and other parts of Europe.
To try and reduce the peak, broaden the peak, not to suppress it completely. Also, because most people, the vast majority of people get a mild illness, to build up some degree of herd immunity as well, so that more people are immune to this disease and we reduce the transmission. At the same time, we protect those who are most vulnerable from it. Those are the key things we need to do. And also allow enough of us who are going to get mild illness to become immune to this, to help with the sort of whole population response, which would protect everybody.
Yeah, I mean, that herd immunity, I know you talked about yesterday when you were appearing with the Prime Minister. In terms of building up a herd immunity within the UK, what sort of percentage of people need to have contracted the virus?
Probably about 60% or so.
When most of the population is immune to an infectious disease, this provides indirect protection or herd immunity, also called herd protection, to those who are not immune to the disease. For example, if 80% of the population is immune to a virus, 4 out of every 5 people who encounter someone with the disease won't get sick and won't spread the disease any further. In this way, the spread of infectious disease is kept under control. Depending how contagious an infection is, usually 70% to 90% of a population needs immunity to achieve herd immunity. Measles, mumps, polio and chickenpox are examples of infectious diseases that were once very common, but are now rare due to the development and introduction of vaccines. Other viruses, like the flu, mutate over time, so antibodies from a previous infection provides protection for only a short period of time. For the flu, this is less than a year. SARS-CoV-2, the virus that causes COVID-19, is like other coronaviruses that currently infect humans. We can expect that people who get infected will be immune for months to years, but probably not their entire lives. Did the UK government toy with the idea of creating herd immunity by letting the COVID-19 virus drip through society? I don't know. There are breadcrumbs to suggest that this was being considered, but once modelling suggested that the mortality rate and burden on the healthcare system would be too great, the UK suddenly changed tack. Within SAGE, the CoSIN group collates clinical information from the usual healthcare records of people of all ages admitted to hospital in the UK to characterise the clinical features of patients with severe COVID-19 in the UK. Mathematical models are useful tools for understanding and predicting the possible course of an outbreak, given a set of underlying assumptions. In the early period of an outbreak, modellers are heavily reliant on empirical data gained from previous infectious disease spread and initial data from the source country. As the infection spreads, progressive assumptions are replaced with solid data on spread attack rate, reproductive rate, mortality rate. This then develops scenarios to guide policy on intervention strategies from the governments. Within each of the SAGE advisory groups, there are subject matter experts from the higher educational centres in the UK. The Imperial College London has been at the forefront of developing the advice to the government. Imperial College freely makes available all their analysis and modelling and can be found on the website contained within this view. These next several views will analyse the preparedness of the UK should a pandemic occur and impact the UK. In 2013, the World Health Organization published this document on pandemic influenza risk management based on their experience and observations during the 2009 pandemic. All countries were urged to use this as a template for developing, amending their pandemic management framework strategies and plans. In 2009, Public Health England published this document, which details the epidemiological, clinical and virological investigations of the first imported cases of influenza infection and their close contacts. This is essential in order to inform guidance and policy in directing the United Kingdom's public health response to a newly identified influenza virus. Dame Deirdre Hine conducted an independent review of the UK's response to the 2009 influenza pandemic, which was published in 2010. In her summary, she says the majority of the evidence leads me to judge that overall the UK's response was highly satisfactory. The planning for a pandemic was well developed, the personnel involved were fully prepared, the scientific advice was expert, communications was excellent, the NHS and public health services right across the UK and their suppliers responded splendidly, and the public response was calm and collaborative. That said, it must also be acknowledged that the H1N1 swine flu pandemic virus was milder in its general impact. The dangers of another more severe pandemic has not gone away, and the governments in the UK must avoid complacency and use this opportunity to learn lessons and make improvements for a future in which resources might be tight. The UK Department of Health released in 2011 their document, UK Influenza Pandemic Preparedness Strategy. The UK Cabinet Office initially developed a National Risk Register of Civil Emergencies in 2008. This was updated in 2012. In both the 2008 and the 2012 version of the document, the number one, the highest priority, risk, was a pandemic. The UK Cabinet Office in 2012 released a document titled Enhanced SAGE Guidance, a strategic framework for the Scientific Advisory Group for Emergencies. One of the most important documents released by the UK Cabinet Office in 2013 was the UK central government response, the concept of operations for responding to emergencies. Public Health England released in 2014 their document, Pandemic Influenza Strategic Framework. This was followed also in 2014 by the release of the Pandemic Influenza Strategic Plan. In 2015, the NHS England released their document, Emergency Preparedness, Resilience and Response Framework. And in 2017, NHS England released their document, the National Incident Response Plan. The UK government and devolved governments across the UK released early March this year their Coronavirus Action Plan, a guide to what you can expect across the UK. Earlier this month, the UK government published Our Plan to Rebuild, the UK Recovery Strategy. All countries are encouraged by the World Health Organization to frequently test their capacity for managing a pandemic, continuous improvement. Exercises fall into three broad categories. Tabletop exercises, which involve assembling the major stakeholders in the plan to talk through a scenario, describing actions that would be taken at each point. This type of exercise is most effective in validating plans and policies, and is an effective training and validation tool for procedures. Functional exercises, in which the participants actually complete certain actions while working through the provided scenario. This type of exercise usually focuses on the coordination of multiple functions or organisation. The functional exercise strives for realism, short of actual deployment of equipment and personnel. Full-scale exercises stimulate an emergency event as closely to reality as possible. This type of exercise involves all the named responders in the plan and requires deployment of personnel and equipment. In 2007, the UK held Exercise Winter Willow, which involved 5,000 people. All the actions and learnings from that were incorporated within the National Strategic Framework, CONOPS, etc. Exercise Cygnus was performed in October 2016, and close to 1,000 individuals participated over a few days to test the UK's pandemic response plans. The key learnings from that is the analysis of the evaluation reports from the organisations participating in the exercise indicate that UK's command and control and emergency response structures provide a sound basis for the response to pandemic influenza. However, the UK's preparedness and response in terms of its plans, policies and capabilities is currently not sufficient to cope with the extreme demands of a severe pandemic that will have a nationwide impact across all sectors. Exercise Cygnus demonstrates 4 key learning outcomes for the UK's preparedness and response capabilities, which are supported by 22 detailed lessons against the 8 exercise objectives. Feedback from the exercise planning and delivery indicate that in England, at the local level, there is a variable understanding of the current response arrangements and that individual organisation responses rely on a corporate memory of the 2009 H1N1 responses, which is currently being lost. Some organisations took part in Exercise Cygnus with plans missing or plans that had been produced in the months leading up to the exercise, which meant they had not been trying to their plans. Considerations should be given to the development of an overarching pandemic influenza concept of operation, which would assist in the operationalisation of the response at strategic level and tactical level by describing the roles of the organisation in a pandemic influence response. There is no doubt that COVID-19 has been a monumental shock to countries' supply chains, and aside from a surge in demand and shortage of medical supply and manufacturing, one of the biggest issues for supply chains in healthcare so far has been the spread of medical protectionism. Nations have banned the export of medical equipment and medication to meet the anticipated demand at home. Medical supplies are confiscated at border crossings. Medical supplies are purchased suddenly, rerouted because another nation has paid the manufacturer, the supplier, considerably more money. The majority of Western countries' stockpiles since 2000 have held a pandemic national stockpile. But over the years, these stockpiles have not been maintained, reduced and outsourced to private enterprises. The next views walk you through the UK's supply chain journey.
Why, oh why, oh why were we not involved in EU procurement?
We left the European Union on the 31st of January.
No, we had every right to take part. We were invited to take part. Apparently we missed the emails or forgot the emails or didn't ask for emails. 5 of the meetings we didn't attend, but lots of the other meetings we did attend. It's not about leaving the European Union.
All I can say is, as a matter of fact, we have not taken part.
Maybe I could ask Sir Simon, what was your policy advice on it, or was it a political decision?
It was a political decision. The mission, ARC-MIS rather than ARC-REP, Brussels, briefed ministers about what was available, what was on offer, and the decision is known.
It's fair to say that almost every country has experienced chaotic supply chain issues in relation to sourcing adequate medical PPE, gowns, masks, face shields, gloves, ventilators, etc. The 2009 swine flu pandemic led to a rapid anti-pandemic reaction among Western countries. The H1N1 09 virus strain, with mild symptoms and low mortality, eventually led to a backlash over public sector overreactiveness, spending and the high cost benefit of the 2009 flu vaccine. Many countries adopted a just-in-time strategy over an over-reliance with the provision of medical PPE from China, rather than diversifying their supply chain for critical pandemic medical supplies. The UK government attended several meetings with their EU counterparts, but chose not to participate in EU-wide purchasing agreements for pandemic medical equipment. Despite growing discontent with frontline healthcare providers at the lack of critical medical PPE and equipment, the government maintained their message, their priority to ensure frontline staff had PPE they required, even if they had to reuse it several times, or being chastised for using too much. Testing chemicals were not available, so limiting the number of tests being conducted. Yet companies contradicted the government that there was ample supply of chemicals for testing. Who had access to tests and the methodology applied to testing was confusing. The government tried initially to centralise testing. I suspect that after this pandemic is over and the public inquiries and investigations are commenced, the UK's strategic pandemic stockpile distribution testing strategies will be judged inadequate and potentially cost the lives of frontline workers and citizens.
So we've got a huge programme of work making sure that millions of masks, of aprons, of gloves, of all the other equipment, the hand sanitizer, that they're delivered, and at the same time buying all the equipment, because while we've got stores now, we're working through them and we've got to make sure that we buy that equipment. It's all about doing everything we can to keep the frontline NHS staff, social care staff safe while they do their duty for the country.
You are apologising for the lack of PPE, which has led to mass infections and deaths of several nurses and doctors.
I have been very clear in what I have just said, and I'm sorry that people feel that way, but I do want to say at the same time that we are doing everything within our power.
There is a global call for answers as to why a relatively simple viral organism has wreaked havoc on a global scale. We won't enter into that discussion in this video, but we will comment on the perceived performance of the UK government and whether or not their response was effective. From the 30th of January, the WHO had declared the virus a public health emergency of international concern. Basically, this is a heads up to all nations that there is an emerging virus and to start to dust off their pandemic plans and commence implementing strategies to prevent, mitigate the impact on their populations. European nations commenced meeting to discuss medical PPE on the 31st of January. The UK was present and invited to join a European effort to purchase medical PPE but declined. This must be viewed in the context of general mistrust by the UK government in the various mechanisms of the European Union in establishing themselves as a separate entity from the EU. As the virus spreads from east to west, respectable publications, The Lancet, and scientists from around the world were warning that this was the real deal and countries need to prepare. The first COBRA meeting was held on January the 24th. Boris Johnson did not attend one until March the 3rd. COBRA meetings are chaired by the lead agency. In the case of COVID-19, that's Matt Hancock. The Scientific Advisory Group for Emergencies first generated a report to government on the 3rd of February. In it, they say it is unclear whether outbreaks can be contained by isolation and contact tracing. If a high proportion of asymptomatic cases are infectious, then containment is unlikely via these policies. They further stated the long incubation period means isolation of contacts of cases would need to be lengthy and that entry screening is likely to be ineffective. They also said while there is a role for the less disruptive social distancing measures, such as voluntary home isolation in any pandemic, school closures and the cancelling of public events are generally only justified in very severe pandemics because of their severe social impact over an extended period of time until a pandemic-specific vaccine becomes available. They further stated our results suggest that by the time a single death occurs, hundreds to thousands of cases are likely to be present in that population. March the 13th, estimates of the severity of COVID-19. The first case was identified on the 31st of January. The first death was the 5th of March. In late February, the COVID-19 bomb exploded in Lombardy region in northern Italy and rapidly overwhelmed the health service. Daily media were broadcasting interviews with medical staff near the point of collapse, begging the UK not to make the same mistakes and to prepare. The evidence would suggest that the UK did not prepare. In March, individuals were encouraged to wash their hands and stay home for several days if they had symptoms. Schools remained open. Restaurants and bars traded as usual, and visitors were still allowed into care homes. Flights were arriving from mainland China, even though Australia had banned them 6 weeks earlier. Even public events were still allowed. A Champions League match in Liverpool drew a crowd of 52,000, about 3,000 of whom came from Madrid, where a partial lockdown was already in force. More than 250,000 tickets were sold for the Cheltenham Horse Racing Festival. Politicians have hidden behind their message, following the science. I know, the first time I heard it coming out of the mouth of a UK politician, that they were already mounting their defence strategy for when the public inquiries commence into the pandemic. Experts have also voiced growing frustration over the UK government's claim that it's following the science, saying it has been used to abdicate responsibility for political decisions. Let me be clear. Scientists provide analysis based on best available data. Politicians make and implement policy decisions in relation to the nation. Other prominent science personalities commented. I think that you can see why there's a concern in the scientific community over the "we are following the science" message. It almost seems sometimes like a defence that some ministers appear to have been coached to deploy when asked a difficult question. The next video in the series will focus on wet markets. What is a wet market? Where are wet markets? Why are wet markets frequently implicated in the emergence of novel viruses?